Yeah, Farah, we will. Thank you.
Hello, welcome to the inaugural Southern California Academic Debate. My name is Farah Douglas. I'm the National Director for Engagement for the American Liver Foundation, and I oversee serving 6 states of Alaska, California, Hawaii, Nevada, Oregon, and Washington. I would like to take a moment to recognize our academic debate sponsors this evening. Our national gold sponsor, ASI, our national bronze sponsors, CVS Specialty and Salix Pharmaceutical, our national expo sponsor, Mallinckrodt. Let's take a moment to hear from a couple of our amazing sponsors this evening.
Right now, millions of patients are suffering with GI disorders such as overt hepatic encephalopathy, irritable bowel syndrome, chronic idiopathic constipation, opioid-induced constipation, bowel preparation, and ulcerative colitis. At Salix, we have kept up with these unmet needs for more than 30 years by providing an industry-leading portfolio of high-quality products that address these conditions. Through our dedicated and innovative R&D team, we're also exploring potential new scientific breakthroughs. And we remain committed to important healthcare provider investments in education, charitable grants, and sponsorships. We will continue to invest millions of dollars in patient education and do our best to broaden access to Salix medications. Because our mission to improve the care for GI patients continues today. For us, there is no finish line.
Thank you to our sponsors. Before we start, on behalf of the American Liver Foundation and liver patients, I want to acknowledge and thank the healthcare heroes and all essential workers for their tireless and enduring efforts in 2020 and all they have sacrificed and all they are doing to help us and keep us healthy and safe. Tonight, we thank you and we celebrate you. It is my great honor now to introduce our moderators for this evening's event. Dr. Jeffrey Kahn, Associate Professor of Clinical Medicine at Keck School of Medicine of USC and Medical Director, Liver Transplant Program. Dr. Kahn is also a member of the American Liver Foundation's Medical Advisory Council. Dr. Sundaram, Director hepatology outcomes research, and assistant medical director, liver transplantation at Comprehensive Transplant Center, Cedars-Sinai. Dr. Sundrom is also a member of the American Liver Foundation's Medical Advisory Council. Dr. Sundaram, you have the floor, please.
Okay, thank you very much for the introduction, Farah. Good evening to everybody, and welcome to the Southern California Academic Debates. I'm very happy to be one of the moderators along with my colleague, Dr. Khan, and our debate will feature judges, mentors, and of course, fellows and participants whose work is vital to the liver community. The mission of the American Liver Foundation is to promote a combination of education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. I am proud to be part of the American Liver Foundation's Medical Advisory Council and to serve the greater Los Angeles area. While this year's academic debates are virtual, we are excited to host this informative session and to thank the participating institutions. Thank you also to the American Liver Foundation staff who have worked hard to arrange this debate during these difficult times. And thank you, of course, to all the members of the audience for watching and for your support. This evening, we will have two debates, which includes a brief intermission and a judging session for each debate. The topics tonight don't have a right or wrong answer. It's just an opportunity to hear different points of view and to learn from each other. The debaters will be judged on multiple criteria such as presentation, delivery, and summation by our outstanding panel of judges. And as a moderator, I will serve as the tiebreaker in the event of a tie, though there are an odd number of judges, so I don't believe that will happen. And now I'd like to introduce Dr. Khan, who is my co-moderator for tonight.
Yeah, thank you very much for joining us tonight. And I must say that one of the interesting aspects of having Zoom meetings like this is actually to have judges who are from all over California. So I think that's really a benefit. So our judges tonight, so Dr. Neil Biani, who's the Director of Liver, Pancreatic, and Complex Cancer Surgery, Director of Reflux and Esophageal Disease at the Association of South Bay Surgeons, Chair of the Liver, Pancreas, and GI Cancer Program at Charles Memorial. Dr. Bilal Hamid, who I had the pleasure of meeting a couple of years ago at the ASLD up in San Francisco, who's the Associate Professor of Medicine, Hepatology Clinical Chief at UCSF, and Section Editor for Gastroenterology, one of our big journals in GI. Dr. Aparna Goel, who's Clinical Assistant Professor at Stanford in GI and Hepatology. Dr. Lally Melstrom, who's the Assistant Professor, Division of Surgical Oncology, Department of Surgery at City of Hope here in Southern California. And Dr. Judong Yang, who's Assistant Professor of Medicine in GI and liver diseases at Cedars-Sinai Comprehensive Transplant Center. I just want to make sure that even though we have all of our fellows and people that are presenting tonight, it's competitive, but I want it to be friendly and fun. And really, I want everybody to sort of learn from the experience. And I think it's really good to sort of get together. We haven't done this before in this part of Southern California. I was actually a moderator down in San Diego last year for a similar program that was actually live. And I think this is actually a really nice forum for our fellows and everybody who's participating. And I just want to mention that anybody who's on this link has the opportunity to donate to the American Liver Foundation, which is a great cause. And that would be wonderful if people want to donate. So I'm going to send it back to Dr. Sundaram, who's going to discuss the next aspect of our program tonight.
Okay. Thank you, Dr. Khan. So we will begin tonight's academic debates. Just to review the format, each fellow will have 8 minutes to make the initial presentation for their case. After each presentation, the teams will have 5 minutes for a rebuttal, followed by around 1 minute for closing remarks to summarize their positions. The topic for the first debate is TIPS versus BRTO for the treatment of bleeding gastric varices. We have two institutions, Loma Linda University, who will present in favor of BRTO, and UCLA, who will present in favor of TIPS. I'd first like to introduce the team from Loma Linda University. Their mentor is Dr. Michael Volk, who is the medical director of liver transplantation, as well as the division chief of gastroenterology at Loma Linda. And Dr. Volk, would you like to introduce your fellow?
Hi, everyone. Dr. Curtis Martin is a GI fellow at Loma Linda with us, and she actually did her medical school and did 5 years of basic science research in portal hypertension in Madrid, which is kind of one of the meccas of portal hypertension. So we look forward to her presentation.
Thank you, Dr. Polk. And then please help me welcome Team UCLA. The team's mentor is Dr. Edward Lee, who is an associate professor of radiology, and their advisor is Dr. Arpan Patel, who is an assistant professor of medicine at UCLA Medical Center and the VA healthcare system. Dr. Patel, would you like to introduce your team members?
Yes, it's my distinct pleasure to introduce our two team members. First, we have Dr. Adam Winters, who is a third-year gastroenterology and hepatology fellow at UCLA. He'll be presenting our argument in favor of TIPS. And our second person on our team is Dr. Zachary Haber, who's in residency for interventional radiology at UCLA, and he'll be presenting our rebuttal. And we are excited to have people on our team who will also be pursuing careers in liver. And so it's just a distinct pleasure to be introducing them.
Okay, thank you very much. So what I will do is I'll present the case, and then we will move forward with starting the debate. So this is a case of a 57-year-old female with a history of alcohol use disorder. She presented with acute hematemesis. Her medical history is notable for alcohol use disorder as described, along with bipolar disorder, which was believed to be well controlled. She has no known prior history of liver disease. Prior to presentation, she had no symptoms of decompensated cirrhosis. Her social history included drinking 4 to 5 beers daily for a period of 25 years. She had no history of tobacco or IV drug abuse, and her only medication was Wellbutrin. On physical exam, she was tachycardic. Her sclera were icteric. She was oriented ×1, but somnolent with asterixis consistent with grade 3 hepatic encephalopathy. Her abdomen was distended but non-tender. Some of the initial labs on presentation, she was anemic with a hemoglobin of 5.6. She was thrombocytopenic with mild coagulopathy, INR of 1.7, and total bilirubin of 3.2. Her creatinine was normal at 0.7. Albumin was 2.4. She had an ultrasound with Doppler studies performed, which demonstrated cirrhosis with mild to moderate ascites, as well as patent portal vessels. A cardiac echo was normal with regards to ejection fraction and PA pressure. Her bleeding was then stabilized with octreotide and Protonix, and she underwent an endoscopy. The endoscopy revealed grade 1 esophageal varices without stigmata of bleeding, and a single large gastric varix with stigmata of bleeding, though no active bleeding during the endoscopy. Due to the large size of the varix, no attempt was made at endoscopic hemostasis. So the question for both teams is, should the patient undergo TIPS or BRTO for treatment of bleeding gastric varices? And the first team to present will be Loma Linda. Are you ready? Okay, and if the timekeeper is ready, we can begin.
Thank you. Thank you so much for inviting me here today. Thank you, my mentor, Dr. Volk. And I'm Diana Carrez, I'm a first-year fellow, and I'll be debating about BRTO versus TIPS, and I will favor BRTO. But gastric varices, and including esophageal varices, are the major complication of portal hypertension. Gastric varices are, according to some series, between 15 to 30% incidence. However, it does carry a higher risk of complication and mortality and morbidity. And the reason behind it is because the brisk blood flow through the gastric varices in comparison with the esophageal varices. Therapeutic approach that have been explored in the past include surgery, endoscopy, and interventional, where surgery back in the 70s, as well as endoscopy, hasn't been proved to be superior to interventional. And the interventional options that we have today, first TIPS, which is the treatment of choice so far, until recent years where BRTO came into the surface. But what is BRTO? Balloon-occluded retrograde transvenous obliteration is a technique used by interventional radiologists. And the purpose of it is access either through transjugular or transfemoral access. And as long as there's a shunt between a gastric vein and a renal vein, you can access through a catheter and use sclerotherapy to block and clot that shunt. What we use, absolute alcohol could be used, gel foam, ethylamine. Ethylamine is interesting because that was the first one that was used in Japan, where this technique was discovered and developed. But also there's a few variations, Carto and Parto, where they use coils and plugs. I will point out at this point that this requires the presence of a shunt. But is BRTO effective? I would like to bring this study because this was performed by Fukuda and collaborators in Tokyo, Japan, where this technique was initially explored. And they followed these 43 patients, and they did this in a prospective study. And they, after BRTO was performed for gastric varices, they performed 12 months endoscopy, vision, and 30 months period afterwards. And they got to these conclusions. First, gastric varices disappeared, or at least decreased in size in all the patients, and hepatic encephalopathy completely resolved in those patients. In addition to that, there's a cumulative relapse-free survival rate, 90% 1 year and 87% 3 years after BRTO. In addition to that, there was an improvement on the Shadpo score that was observed in 50% of the patients in the 6-month period after BRTO, and 25% of the patients after a year of BRTO. So to answer this question, yes, BRTO is definitely effective. But is this superior to TIPS? Well, there's this PRAY meta-analysis that was published in 2016, and they go over 5 different studies, original, that they compare TIPS and BRTO. And they couldn't find any difference between the technical success of both techniques or the hemostasis rate, but also they couldn't find a difference between post-op complications associated with those techniques. However, BRTO showed a lower incidence in post-op rebleeding, as well post-op encephalopathy that was prior described. But what are the pros and cons of BRTO? Well, I would say probably will be more effective in preventing rebleeding, as the study has showed, and there's a less risk of encephalopathy, and it also actually can resolve encephalopathy. However, might worsen ascites and esophageal varices, because all that blood flow have been diverting from the gastric varices is gonna go to the portal system, and of course it's gonna increase the pressure, so that will develop in ascites and worsen, esophageal varices. And there's one thing, not all institutions are prepared to offer BRTO, and it does carry some technical difficulties, and sometimes it cannot be offered right there when the patient needs it. Sorry about that. So in this patient that was presented before, what would be the best? Well, I think BRTO, and the reason is this patient does have minimal to moderate ascites, has a small esophageal varices. The patient at that point was stable, so the goal was to prevent rebleeding at that point. And assuming that the technique is available and feasible, meaning that there's a presence of the shunt, then I would say that this patient might benefit from BRTO over TIPS. Thank you so much for listening. And I just want to share briefly this picture I took this morning in Lake Tahoe, where I have been snowboarding till now. Thank you.
Okay, thank you very much for your presentation. And now we will start the initial presentation from Team UCLA. So once you're ready and the timekeeper is ready, we can get started.
We at UCLA are pleased to represent the side of TIPS in this argument, and even more excited to bring the perspective of our multidisciplinary team, incorporating input from both hepatology and interventional radiology. Given the complexity of this case and the proposed interventions, I think it might be more instructive to view this case from the lens of treatment, less from the lens of treatment of bleeding gastric varices, and if you'll allow, more from the perspective of the treatment of this particular patient, who, as you've heard, has a lot more than gastric varices to consider, particularly when considering the patient's long-term health in combination with the best short-term treatment. Over the next few minutes, we will demonstrate why TIPS is the superior option. To summarize what we know about our patient and to help us lay out the roadmap for why TIPS is superior in this case, this is a new diagnosis of decompensated cirrhosis with new onset of ascites, esophageal varices, and encephalopathy. She has the gastric varix with stigmata that has not been treated and is prone for rebleeding. But we need to address what we don't know about the patient at present. In order to successfully perform a BRTO, the patient will require the presence of a gastrosystemic shunt. As we lack cross-sectional imaging in this patient, it is impossible to determine the feasibility of BRTO. In order to undergo a BRTO, the patient will require a CT scan to document the presence of an acceptable shunt, which is absent in up to 60% of patients. With the information we have currently, with demonstration of a patent portal vein, should the patient rebleed, which is quite likely, requiring an urgent intervention, we feel comfortable knowing that TIPS is possible. BRTO, not so much. And we know that TIPS is extremely effective at providing immediate hemostasis in bleeding gastroesophageal varices. Various reports have the hemostasis rates for gastric varices is up to 96%, which is comparable to BRTO. Historically, rebleeding rates for TIPS have been higher than ideal due to stent occlusion. However, much of this data originates from the use of bare metal stents. Since the advent and widespread adoption of polytetrafluoroethylene covered stents, stent patency has improved dramatically to 90% at 1 year, with a reduction in rebleeding rate to less than 10%. Most transplant centers now perform variceal coil embolization routinely during TIPS, a technique to further prevent rebleeding. With a combination of covered stents and performing variceal coil embolization at the time of TIPS, rebleed rates have dropped even further to as low as 0%. The graph you see on the right is a comparison of patients with acute hemorrhage undergoing TIPS placement, either with or without embolization. You can see those that received embolization had no further rebleeding events at 4 years. The second Kaplan-Meier analysis is from a randomized control trial comparing endoscopic and medical therapy to covered TIPS, including patients who underwent embolization. Again, using covered stents and employing embolization led to no rebleeding events at 36 months. With respect to hemostasis, BRTO and TIPS are equivalent. In a meta-analysis of 7 studies comparing TIPS to BRTO, there is no significant difference in hemostasis rates between the 2 modalities in the 4 studies that reported such outcomes. When the analysis shifted attention to the rates of rebleeding, BRTO had a statistically significant advantage in rebleed rates. However, if you look at 3 of the 4 manuscripts that confirm the use of covered stents, there is no significant difference in rebleeding rates. This lends credence to the data presented earlier and the importance of covered stents as a method of preventing stent occlusion precipitating rebleeding. It's worth noting that the use of variceal coil embolization was not used uniformly throughout these studies, though we can imagine that it would be to the benefit of TIPS. We've discussed the role of TIPS for treatment of the bleeding gastric varix and shown that TIPS is comparable to BRTO in hemostasis and rates of rebleeding. But given the severity of disease, our patient is at significant risk of other complications of portal hypertension. While her esophageal varices were noted to be small in endoscopy, the fact is, if we were to subject her to BRTO, as our friends at Loma Linda would like, that would probably change. In a study of 78 patients who underwent BRTO, worsening of esophageal varices were noted in 27, 57, and 66% at 1, 3, and 5 years, respectively. 36% of patients who had pre-existing varices had worsening at 1 year, and you can see how precipitously the risk increases as time goes on. Worse, 50% of patients with worsening esophageal varices post-BRTO go on to bleed. I know I don't need to remind this crowd that the mortality from esophageal bleeding is up to esophageal variceal bleeding is up to 20% at 6 weeks. Loma Linda would argue that these can be treated by routine endoscopy, but now they've solved one problem and created another. We're subjecting this patient to frequent endoscopy and sedation and the risks therein. On the other hand, TIPS would also take care of those esophageal varices. In a randomized controlled trial that was mentioned earlier from 2016, Holster found that covered TIPS was superior to band ligation and non-selective beta blocker, the therapy this patient would need if she went to Loma Linda. The other benefit, which should not be undersold, is after TIPS, this patient would not require any additional surveillance endoscopy, thus removing the risk of banding, such as post-banding ulceration, and the effects of sedation. If it's a complication of portal hypertension, rest assured that BRTO will make it worse. The cross-sectional images above show an unfortunate before and after of 2 patients in a 27-patient series where over 80% had aggravation of or new onset ascites. In another series of 49 patients published in the American Journal of Röntgenology, Cho found that 44% of those undergoing BRTO developed new onset ascites and 72% developed new portal effusions, both potentially symptomatically bothersome to the patient and both high-risk nodi of infection. Meanwhile, TIPS significantly reduces refractory ascites, particularly in comparison to paracentesis. When compared to patients who do not undergo TIPS, patients with portal hypertension treated with TIPS erase their risk of death from SVP. This is reflected by a mortality benefit for patients with refractory ascites who have TIPS, including those who are child C, like our patient. But I do want to take a moment to address the elephant in the room, the fact that the patient has hepatic encephalopathy, rightly considered one of the most important relative contraindications to TIPS placement. We know that TIPS puts the patient at risk for developing de novo HE and could potentially exacerbate existing encephalopathy. But the presence of encephalopathy post-TIPS is predictable and manageable, and there's a notable example in the literature that illustrates this point. Presented here is a prospective study of 78 patients who were treated with covered TIPS and followed for a median of 20 months. While the covered stent is appreciated for its patency, the improved patency is felt to potentially worsen encephalopathy. In this study, about 44% of the patients developed encephalopathy. However, only 6 of them did not respond to typical medical therapy. Once those patients had their shunt reduced, all of them had resolution of their HE. Again, the onset of encephalopathy is predictable and manageable with standard medical therapy, and TIPS resizing can treat those cases which are refractory, which still represents a distinct minority. With that in mind, let's summarize the consequences of each approach. Our patient has a gastric varix at high risk of rebleed. To be fair, BRTO would provide excellent hemostasis and offer low rebleed rates. However, with respect to the patient's esophageal varices, BRTO would worsen them, increasing the risk for catastrophic bleeding and require ongoing invasive endoscopic surveillance. Lastly, for our patient's ascites, BRTO would again worsen it, potentially increasing the patient's symptom burden and increasing risk for dangerous infections. On the other hand, TIPS would also provide excellent hemostasis and offer low rebleeding rates using covered stents and coil embolization. TIPS would also decompress esophageal varices and eliminate the need for further endoscopy and risk of sedation. TIPS would also treat the patient's ascites, potentially removing a potentially devastating nidus of infection. And so for our patient who has numerous complications of portal hypertension, it's not just about treating the gastric varix, but about treating the patient globally. The best option for this is clearly TIPS. Thank you.
Okay, thank you very much. That was some really interesting data you presented. So at this point, Loma Linda University can present their rebuttal, for which they will have 5 minutes. And as soon as they're ready, they can start.
Thank you so much. Thank you, Dr. Winters. That was a wonderful presentation, and I appreciate all you did with your slides. And we are here because we care about patients, and we would like to do evidence-based medicine, and as well, we would like to do precision medicine. I think you made an interesting point, and I would like to point something out. TIPS doesn't take care of ascites 100%. There's a high chance of recurrence. Number 2, yeah, it does. TIPS takes care of esophageal varices, but actually BRTO, there's a controversial data out there that might not worsen esophageal varices. I didn't want to bring this up here before because maybe it was too much at the beginning, but there's a conflicted data, so that's not 100%. And in this case, I believe that the fact that this patient already presented with hepatic encephalopathy might put her at a higher risk to develop and proceed having encephalopathy in the future. So that's something that should be taken in consideration. And ultimately, we have to present the options to the patient and the data that we have and our experience, and the patient should take a decision as well. But you're right, TIPS does take care of things that BRTO doesn't. But at the same time, BRTO might actually have a better outcome for the patient in the next 12 months. It's something to look for as well. Thank you.
Okay, thank you very much for that interesting rebuttal. And then from UCLA, they will have 5 minutes for their rebuttal, and then we'll finish up with brief remarks from both teams. So whenever the UCLA fellow is ready, please proceed.
Okay, I think I'm unmuted. Okay, our opponents make some interesting points. I agree with evidence-based medicine, so I'm going to go by that. And I'm going to start with the rebleeding rates in TIPS. It's a good point that TIPS prior showed not as equivalent rebleeding rates, as good of rebleeding rates as BRTO. But just a quick overview of that pathogenesis in 1999, Barrage et al. Demonstrated that 70% of rebleeds had associated TIPS dysfunction. That being said, it was usually TIPS stenosis or thrombosis due to biliary ingrowth. Because of that, new stents were developed, covered stent, as Dr. Winters talked about, with patency rates up to 90% compared to previous stents of 30%. That was Said et al. In 2011, did a review of the literature. And not surprisingly, this was associated with significant decreased rebleeding rates in TIPS patients. Holster et al. In hepatology in 2016 did a randomized controlled trial, which we showed the chart for earlier, and demonstrated 0 rebleeds over 36 months using the covered stent and associated esophageal-variceal embolization concurrently, which is the standard of care if feasible during TIPS procedures, at least at modern places, and so should be undertaken because of this. Our colleague, our opponents demonstrated or brought up the Fukuda study in 2001, but this was before covered stents. It's not applicable to newer data, stronger data with modern techniques. The stent came out around 2003 and became more widely used since then, much more used. Also, just briefly touching about rebleeding rates, our opponents brought up the Yubing Wang meta-analysis in Journal of Gastroenterology and Hepatology in 2016. I actually reviewed that as well during my literature search. And as talked about previously, many of those studies in that meta-analysis did not use covered stents or state about covered stents. And on top of that, 2 of those studies in their meta-analysis were actually not even published journals. They were referencing abstract presentations at scientific conventions. I only bring this up by pointing out that maybe it doesn't apply to the modern approach. I'm going to move on to the hepatic encephalopathy because that is an important point with TIPS procedure. This patient has never been on medical treatment for hepatic encephalopathy, and acute bleeding is likely contributing to her acute state rather than a chronic baseline hepatic encephalopathy. But regardless, the most important, at least in my mind, is the clinical consequence of hepatic encephalopathy. And if you look at the data, it shows a different story. So when you look at TIPS patients and subsequent hepatic encephalopathy, a minority of them require TIPS revision or reversal. We cited earlier Riggio at American Journal of Gastroenterology in 2008 showed that 78 patients that underwent modern TIPS, only 6 of those required TIPS reversal. And in fact, the meta-analysis that was brought up by our opponent, Yunbing Wang, in Journal of Gastroenterology and Hepatology in 2016, if you look at their data, only 3% of TIPS patients with hepatic encephalopathy required reintervention, just highlighting that conventional medical and dietary management is very effective in these TIPS patients. I will also bring up, with my time left, the technical points of BRTO. We're not sure that this patient has a gastrosplenorenal shunt, but let's assume they do. Just in the pathogenesis of BRTO, BRTO worsens portosystemic gradient hypertension. It increases it. Because of this, you get worsening esophageal varices, as we cited before, about 36% at 1 year, and 50% of those rebleed per Said et al. In 2011 review of the literature. They get worsening ascites. This patient already has ascites, up to 44% and also new pleural effusions in 72% by Cho et al. And associated increased risk of SBP. Yes, BRTO has been shown to improve liver function, but this is often transient, reversing in about 6 to 12 months. And because of these, BRTO patients often require surveillance with increased rates of para and EGDs, and those have their associated risks. They are low, but they're still associated. And I think one of the points that hasn't been made that I'd like to make is BRTO is permanent. Once it's done, it is done. It has happened. TIPS is not. As we've alluded to, TIPS can be reversed and it can be revised depending on it. So I think I'll leave it there. Thank you.
Okay, great. Thank you very much. And then finally, for the summarizing remarks, each team will have about 1 minute. And whenever Loma Linda is ready, please feel free to give us your summary remarks.
Thank you. Yes, indeed. I think tips can be done in most hospitals, and it's technically more approach than to do BRTO. And indeed, in this patient in particular, it will take care of esophageal varices as well as ascites. However, my worsening encephalopathy, which is a good point Dr. Haber pointed out, ascites might be managed with medications, and you will say, well, encephalopathy could be managed with medication as well. However, if you think about it, what makes us human is the way we think, the way we act. And no one would like a friend, a family member losing that capability. So I think that the fact that tips might worsen encephalopathy in this patient might be taken in more consideration, bring to the palestra even more than ascites. And indeed, putting a patient under surveillance with endoscopy for esophageal varices carries a risk, as you pointed out as well. However, this patient has mild, small ascites, esophageal varices, which might not worsen after BRTO. So something to bring that up as well. Thank you.
Okay, thank you very much. And then finally, for the closing remarks from UCLA, and then we'll introduce the judges and allow time for the judges to ask questions.
Okay, so I think in the concluding statements, our opponents have made some decent arguments, particularly about hepatic encephalopathy. I will just push back one last time that we don't want to leave our patients encephalopathic. I guess my argument is that they are well managed post-TIPS, and it's not that we leave them hepatic encephalopathic. But I think what this comes down to is the underlying physiology and how each procedure addresses it. TIPS improves portosystemic hypertension. BRTO worsens it just physiologically. Because of this, TIPS improves ascites with associated mortality benefit from decreased SBP and decreased risk of recurrent procedures. BRTO worsens ascites up to 44% with new pleural effusions up to 72%, again, Cho et al., and associated increased risk of SBP. TIPS improves esophageal varices with associated decreased esophageal variceal bleeding rates. BRTO worsens it, esophageal varices worsening at 36% at 1 year, and 50% of those rebleed. And that's Perset et al. In 2011. Post-TIPS patients don't require routine surveillance, unlike BRTO patients, as we've pointed out previously. And TIPS patients are usually, and newer techniques associated with TIPS include covered stents and esophageal variceal embolization have demonstrated similar rebleeding rates as BRTO, with immediate bleeding control shown by Holster Hepatology in 2016. And TIPS is a reversible or revisable procedure. So in conclusion, TIPS with covered stenting and esophageal variceal embolization offers the best long-term health outcomes with similar short-term outcomes, making the choice clear for TIPS in this patient. Thank you.
Okay, thank you very much. So now we'll go to the judges for questions. I guess I'll just wait for the video to be available for each of the judges. Okay. So what I'll do is I will just go in alphabetical order to make it simple. So Dr. Bayani, do you have any questions?
Thanks, Vinay. Question actually for both teams. We only briefly touched on the effect of the given procedures on hepatic function. There is some data, though obviously there's conflicting data, that BRTO either preserves or perhaps even in the short term improves hepatic function and Child's-Pugh scores and MELD scores. So I'd like to give you guys both a chance to discuss the improvement or decrement or changes in hepatic vascular flow and any function that goes with it over the, let's call it the 1 year span post-procedure.
Okay, thank you for the question. I'll start with the Loma Linda team. Would you like to answer Dr. Biani's question?
Hi, Dr. Biani, thank you for your question. Yeah, indeed, there's conflicted data. However, there's a study that was done by Fakuda, one in 2016 and the second one in 2019. And in a year, it does improve the Child-Pugh score. However, long-term, it doesn't seem to be the case, to be honest with you. it does shows only 25% of the patients, 20% of the patients in a different study that might actually improve 30 months after. So long term is very hard to assess and to answer your question.
Okay, thank you. And then from the UCLA team, Dr. Winters or Dr. Aber would like to answer the question.
Sure, I'll answer the question. Thank you for the question. As was mentioned, there's certainly data that BRTO does improve hepatic function, but it's a transient benefit. It doesn't last past 1 year. We also have good reason to think that this patient's liver is going to improve on its own. This is a new diagnosis of liver disease, and hopefully that she'll remain abstinent from alcohol. Her liver function will improve on its own. I think the risks of increasing portal hypertension are more immediate than the potential 6 to 12 month benefit of performing a BRTO, which may or may not improve her hepatic reserve or hepatic function.
Okay, thank you very much. Dr. Biani, any other questions?
I'll give the other judges a chance and see if we can circle back.
Sounds good. I'll go to Dr. Goel next.
Hi, all. Thank you for the very interesting discussion and the points that you brought up on both ends. I'll start with a question to the UCLA team. The one concept that I don't think was entirely brought up was obviously the real risk that TIPS can cause catastrophic hepatic decompensation. And while the MELD for this patient was only 17 and Billy was 3.2, that sort of puts the patient at a borderline risk. And when transplant isn't an option, what is your thought about putting a patient through that risk versus if you do a BRTO, and if you do potentially worsen portal hypertension, you could always follow that up with a TIPS after?
I'll take this one. Yeah, I think it's a good point. The MELD is high for considering a TIPS. The one thing I will say is that this patient has been stabilized. This patient's been stabilized with conventional measures, and we don't have to emergently bring her to the IR suite. I would say urgently, but not emergently. So it gives us this nice opportunity to optimize her, to give her, what we believe to be the better procedure. So specifically, her MELD NA, she's hypovolemic and hyponatremic. You could just give sodium repletion for a pretty significant improvement in the MELD just right there acutely. So I think we have this opportunity to optimize this patient and decrease that risk with TIPS. Now for the other side, I agree that BRTO could be performed and then TIPS following. The only thing that I push back is procedures aren't without risk. BRTO is not without risk, and TIPS is not without risk. So I just think if there's an opportunity to perform one procedure instead of two, that I would prefer that. I'm not saying that it's not an option, but I'm just saying that I think if you could optimize this patient, which I do believe you can, to proceed with TIPS rather than BRTO.
Thank you very much. That was great. So now I'll ask Dr. Hamid if he has any questions.
No, excellent presentation. It's very informative. Again, taking the point which Dr. Goel has mentioned, how much beside the MELD score and liver function, what do you think about the age matters? Does it matter into your decision if someone has a BRTO versus TIPS? And that's one of the questions that we always take into consideration. And to the UCLA team, especially to the interventional radiology, about the stent size, because do you think that putting a different size of stent will help your hepatic encephalopathy in this patient?
Okay. Yeah, so I think the age is a good point. I'll just quickly say that I've heard an argument for TIPS very quickly, that given her younger age, that these more long-term complications, I would argue that you have more benefit to see that TIPS rather than something acute, potentially. I don't have much data to back that, so I will just say that's my belief. The only other thing, though, that I'll agree with is the newer stents, the Viator CX, if we're getting very detailed, you can dilate it to an exact size and it doesn't keep expanding to like 10 millimeters like the previous one. So I think this is a good point in someone that is demonstrating some encephalopathy. We could slightly undersize it, maybe at like 7, 8 millimeters, and leave it there and it would not expand, and then see how they do. And if they don't, it's a very easy procedure to just put a balloon and expand it, a millimeter or another millimeter if needed. So that is definitely an option that we employ, and I think that would be a great option for this patient for those reasons that we bring up from this case.
Thank you very much. I'll next go to Dr. Melstrom if you have any questions.
I don't have any questions, but I do have a comment that I really appreciate the nuanced answers that the three discussants have brought up tonight. Excellent.
I would agree. It's very well researched and well presented. Finally, I'll ask Dr. Yang if you have any questions.
A great presentation to both teams. And just a quick question. Does type of the gastric varices matters in selecting TIPS versus a BRTO? Yeah, there are like two different type of the gastric varices, like isolated gastric varices. I don't know, actually, I didn't do the really great literature search, but TIPS may not be as effective for treating isolated gastric varices. Isn't that true?
So I'll ask the Loma
Sure,
and then I guess, so your question is, does the type of varices matter in terms of TIPS versus BRTO? And so I think that's applicable to both teams. So I'll ask the Loma Linda team for their comment, and then we can ask the UCLA team.
Yeah, I don't think for BRTO the size matter, but I do think that TIPS might be a better option when you have multiple viruses versus a single one, especially when it's fungi. I think BRTO would do a better job in comparison when you have in the body and the fundus as well.
Okay, thank you. And then if anyone from the UCLA team wants to comment.
Sure, I'm not aware of any data that suggests a benefit, whether they're isolated gastric varices or esophagogastric varices. I think the only consideration that I'm familiar of that would be pertinent to this case is the presence of esophageal varices in addition to the gastric varices. Makes us think that TIPS would be more beneficial here. But to be honest, I don't know any data that suggests that TIPS is less effective for one or the other.
Okay, thank you very much. So if any of the judges have any other additional questions, you can just raise your hand. Okay, Dr. Goel has one more question.
I have one last question. I'm sorry. This wasn't necessarily brought up by either team, so it could apply to either, but does the etiology of liver disease in particular, so in this patient that might have more severe acute alcohol-related hepatitis and be acutely decompensating in this event, play at all a role in the effectiveness and of the downstream complications of either of the procedures, assuming that this patient can remain abstinent following this admission? And how does that alter the risk-benefit ratio of either of these two procedures?
Okay. I'll ask the Loma Linda team to comment first, and then the UCLA team.
Yeah, that's a great question, and I think you bring up a very interesting point that probably favors TIPS actually. Assuming that this patient has a MELD which is driven by an acute alcoholic hepatitis, then the MELD score will be actually lower. So probably this patient will benefit from TIPS better. The second part of your question, I have no information about that, so I would let my colleague Dr. Winters to answer that one.
Okay, it'll have to go to Dr. Winters since you were already volunteered.
Well, thank you. So I think, if the patient is able to remain abstinent and she does regain liver function, I think it speaks to the benefit of TIPS in that it is reversible. We can occlude the TIPS and she can, go on through life, whereas BRTO is forever. The other aspect of it is that there's a lot of uncertainty whether she's going to be able to remain abstinent. And we know that, even mild amounts of alcohol consumption will increase her portal hypertension, which is only going to be exacerbated by the presence of the BRTO.
Okay, great. We will wrap up the Q&A, and the judges will go into a breakout room to make their decision, which will be announced at the end of the debate. I just wanted to say again, to echo everybody else's comments, that thank you very much to all of the fellows and to all of the advisors and mentors for preparing two excellent discussions. Thank you.
Thank you, Dr. Sundaram. What a wonderful first round of debate with LLU Transplant Institute and Team UCLA. I want you to know that the support we receive from both institutions and the services they provide for liver patients is extremely valuable to the American Foundation and the liver patients. Thank you for everything you and your team of excellent physicians are doing for the community. So while our doctors are in their, our judges are in their breakout room thinking and talking about the debates and making decisions, let me remind our audience and guests, please remember that to contribute this evening to the American Liver Foundation so we can continue our work within Southern California communities and across the country. The link to donate is in the chat box on your screen. You can also donate on the debate website. We need your support now more than ever. I just also want to share with you some of my own experiences. Every day I receive emails and calls from liver patients or their caregivers. No matter what, I take time to talk with them or respond to their emails immediately. In these talks and emails, I see how desperately they are looking for help, resources, a way to understand and find courage to fight liver disease and navigate their way through it. Your help will support American Liver Foundation to continue our mission of providing advocacy, services, resources, and education to those patients who need us. From all of us at American Liver Foundation, we thank you for your generosity. Our goal tonight is to raise $5,000. I hope you help us get there. So now I want to share with you an important announcement. On September 15th, we have a beautiful celebration of virtual, of course. We will celebrate accomplishment of wonderful liver specialists. I invite all of you to register. This event is called Salute to Excellence. And we want to thank these doctors who are nominated and chosen by their peers for the work they have done. Our honorees will be from many states. From California, we will honor Dr. Ron Busatel from UCLA, Dr. Irene Kim from Cedars-Sinai, Dr. Christopher Ballas from UC Davis, Dr. Ed Mena from California Liver Institute. I thank you in advance for attending Salute to Excellence. Please look for my email. I will send the special invitation to all of you. Also, let's thank all of our wonderful sponsors, Eisai, CVS Specialty, Salix Pharmaceutical, and Mallinckrodt. I believe our judges are ready to come back now. So I want to thank you, and we are ready for the second. Oh, please, as you see on your screen, join us, share with us, send us your messages on all our social media channels. I thank you, and I would like to invite now our moderator for this section, Dr. Jeffrey Kahn, Associate Professor of Clinical Medicine at Keck School of Medicine of USC and Medical Director, Liver Transplant Program. Dr. Kahn?
Yeah, so welcome back, everybody. And I just want to congratulate the participants in the first half and the judges, and I think that went really nicely, great arguments. So the second half is going to be very similar, 8 minutes for the fellows to present initially, and then 5-minute rebuttals, and then brief closing arguments, and the judges will start asking questions. So the first group up is from USC. The topic will be transplantation of patients with hepatocellular carcinoma or outside of Milan criteria, whether they should be transplanted or not, or wait. And the team will argue in favor or the pro of this argument. That is, patients with HCC outside of Milan within UCSF should be transplanted without waiting for downstaging. And the team USC, the mentor is Dr. Lily Dara, who's assistant professor of medicine. She's an NIH-funded physician scientist, and she is a member of the USC Research Center for Liver Diseases. And Dr. Dara, if you would be able to introduce the fellows.
My pleasure. Hi, everybody. I'm Lily Dara, and I'm here to present to you our two outstanding first-year fellows, Dr. Niharika Malepalli and Dr. Divya Ayala Somayajula. They'll be arguing the pro-transplantation and proceeding without downstaging outside of Milan criteria and within UCSF. Dr. Malepalli comes to us from the Baylor Internal Medicine Residency Program. She received her medical degree at Emory University School of Medicine and an MPH from the Harvard T.H. Chan School of Public Health. Rika is doing the initial presentation, defending our position. Dr. Ayala Somayajula is a Kexter for life, a homegrown talent. She earned her medical degree at the Keck School of Medicine of USC and graduated from the USC Internal Medicine Residency Program. Divya will be doing the USC rebuttal. Fight on.
The Kaiser team is being led by Dr. Rasham Mittal. He's a transplant hepatologist at Kaiser Permanente LA Medical Center. And they're going to be presenting the con argument, that being that patients outside of Milan criteria, but within UCSF, should not be transplanted without being downstaged first. So Rasham, if you would introduce your team.
It looks like Dr. Mittal is having a little trouble unmuting himself. Dr. Khan, if you would just like to introduce
Can you hear me now? Is that better?
Oh, yes, that's working now. Thank you, Dr. Mittal.
Sorry about that. Let me just go back. First, I'm thankful to the American Liver Foundation to extend this invitation to Kaiser Permanente to be a part of this academic debate. For this great debate, I'm mentoring two outstanding gastroenterology fellows. The first main presentation will be done by Andy Tien, who is one of our first-year gastroenterology fellows. He has been associated with several gastroenterology research projects since his residency here at Kaiser Permanente, and the rebuttal will be done by Dr. Elizabeth Dong, who is currently a third-year gastroenterology fellow and will be graduating this year. She has been associated with several of research projects and has done several presentations and has made us proud at different national levels.
Okay, so I'm going to present the case. So it's a 57-year-old man, history of HCV cirrhosis, treated about 5 years ago with Harvoni, had an SVR, a very common presentation that we see. Otherwise healthy, active, works full time, did not have imaging after treatment. Again, unfortunately, something we often see. And but prior ultrasounds in the past have been normal. No history of decompensating events. In January of 2020, he presented with to a new primary physician who obtained laboratory testing and an ultrasound, followed by a CT that showed 2 LIRADS 5 lesions, meaning that they met criteria for HCC based upon LIRADS and OPTN. One was 3.3 centimeters, segment 4A. One was 3.7 centimeters. One was segment 5, 3.3 centimeters, and one was segment 4A, 3.7 centimeters. The AFP was 300 on imaging. There were paraesophageal varices, and on EGD, he had small esophageal varices. His MELD was 7, his liver function was excellent, and his platelets were 110. His blood type was O, and the question is, if a liver becomes available right now, should he undergo liver transplantation? So the pro position is going to be argued by the USC team. Patients outside of Milan criteria, but within UCSF, should be transplanted. The con position, which is going to be presented by the Kaiser team, will be that patients outside of Milan criteria, but within UCSF should be downstage to within Milan before undergoing liver transplantation. So we're going to start with the CAC team.
Good evening, everyone. My name is Rika Malepali, and I would like to share USC's case for the transplantation of patients with HCC who are outside the Milan criteria. When liver transplantation started in the US in 1963, indications for transplant varied and outcomes were poor. There were no clear guidelines for HCC transplantation. The paradigm shift caused by the arrival of the Milan criteria by Mazzaferro and colleagues in 1996 cannot be understated. It was the first widely used risk stratification model for liver transplant in HCC and has been the gold standard. Its findings have been replicated and verified many times over. There was an overall survival of 85% and recurrence-free survival of 92% at 4 years. Unfortunately, the Milan criteria is too restrictive. Several other broader criteria have survival rates comparable to those of Milan. Bottom line, transplanting select patients beyond Milan criteria maximizes transplant benefits for the most number of patients. When we think about our patient situation and the situation faced by many potential transplant candidates who are limited by Milan, we know that we must do better. Fortunately, the survival data for liver transplant patients outside of Milan is robust and promising, most notably the UCSF criteria, which is shown in this image compared to Milan. To fall within UCSF, a patient's HCC has to consist of one tumor less than 6.5 centimeters, or 2 to 3 lesions not exceeding 4.5 centimeters with a total tumor diameter of 8 centimeters or less. No vascular invasion, no extrahepatic spread. Our patient falls within this. The UCSF criteria has survival outcomes comparable to Milan, a fact that has been validated by almost 20 years of studies. In the original 2001 study by Yao and colleagues, 1 and 5 year survival rates were 90% and 75.2%. The study was validated later on many times over, most notably prospectively by Dr. Yao himself in 2007. What has been repeatedly shown, whether by Pavel's 2018 review article or primary studies by Abul Fattah in 2018 or Chen in 2009, is that again, UCSF and Milan have comparable survival outcomes. Taking a step back, I'm sure many of you have seen in practice that tumor size and number isn't everything. Often a tumor's biology and its corresponding aggressiveness are more important. Milan used size and number as a surrogate for microvascular invasion, the best predictor we know for HCC recurrence. But since then, several other HCC liver transplant criteria have found better surrogate markers. Most notably AFP, which at different levels can suggest aggressive tumor biology or even contraindicate transplant. Other studies use biopsies to assess tumor differentiation and MVI, but a biopsy carries procedural risk, sampling error, and a risk of tumor seeding. Downstaging, discussed later in the presentation, argues that time is the most important factor in judging tumor aggressiveness. However, many of the studies referenced below have highlighted dynamic transplant criteria that utilize biomarkers to more accurately account for MVI without increasing wait times to transplant. So how would our patient measure up against a criteria that includes biomarkers? We decided to take a look. Mazzaferro, author of the Milan criteria, in 2009 started publishing about expanded criteria that could include biomarkers. His findings evolved into a calculator called the MetroTicket 2.0. This calculator predicts if a patient falling outside of Milan could still benefit from transplant. It takes into account tumor size, tumor number, and serum AFP. As you can see, we plugged in our patient's numbers and we calculated the results. This dot on the screen indicates where our patient would fall with an AFP of 300, 2 tumors with the largest one measuring 3.7 centimeters. There would be a 5-year survival of nearly 70%. So what does this mean? It means that 1, criteria for liver transplant is evolving. 2, even the authors of Milan supported an expanded criteria. And 3, patients meeting expanded criteria had survival comparable to those just meeting Milan. We also made a table showing several criteria used to evaluate patients for transplant. Row 1 is Milan, row 2 is UCSF. I wanted to point out 2 things. 1, UCSF and every other row describe criteria that are all less strict than Milan. And 2, every single one of them has greater than 70% survival at 5 years. Another aspect of transplant outside Milan is the concept of downstaging. At first glance, it might seem like the risk-averse, cautious choice. You apply local regional therapy, wait till a patient falls within Milan, and then transplant. And then after downstaging, patients within Milan have the same overall and recurrence-free survival as do patients whose HCCs fell into Milan to begin with. However, substantial literature, including the recent Kardashian multi-center study, shows that overall survival is not different between successfully downstaged and not downstaged patients, whether they received local regional therapy or not. In addition, downstage patients involves a 6-month wait period to, quote, observe tumor biology before being listed. Downstaging loses valuable time that our transplant candidates simply do not have. And at the end of the day, it doesn't improve overall survival. Again, awaiting dynamic markers loses valuable time. In our transplant region 5, the median wait time is 12.8 months. In regions with long wait times, intention to treat survival is decreased. There's an increased cumulative incidence of waitlist death and increased dropout rate from medical attention. In region 5, as of last week, there were 2,600 people on the waiting list. And in all of 2019, 1,407 liver transplants were completed. So what does this mean for our well-compensated low MELD patient who had 2 LIRAD-5 lesions, largest being 3.7 centimeters, a total diameter of 7 centimeters, and an AFP of 300? Outside of Milan, our patient met every single criteria for liver transplant. Radiographically and serologically, our patient is set up for success. If there is a liver available, we should proceed with transplant. Our duty as hepatologists is to balance efficacy and quality of life for every single patient. Our patient does not meet Milan, but he absolutely meets criteria for transplant. To close, the Milan criteria was a monumental moment in liver transplant, but is too restrictive. UCSF and other even broader criteria have well-established success in transplant outcomes. Given improved imaging and a better understanding of predictors of survival and recurrence, transplant should be offered to a broader selection of candidates, including ours. Liver transplant should be offered with the minimal acceptable outcomes to provide the maximum benefit for our patients. Downstaging increases time to transplant and increases waitlist mortality without a clear survival benefit. We should transplant our patient now for the best acceptable outcomes. We must transplant outside Milan. We must transplant this patient. We wanted to end with a quote by the physician who created the Milan criteria. More patients with HCC could be candidates for transplantation if the current approach to candidacy, based on the strict Milan criteria, were replaced with a more precise estimation of survival. In conclusion, Divya and I enjoyed the opportunity to really delve into the literature, and we wanted to thank you all for your attention.
Yeah, thank you very much for the presentation. And now we're going to have the presentation by the Kaiser Permanente team, the position that patients within UCSF but outside of Milan's criteria should not undergo liver transplantation without downstaging.
Hi, everyone. So our stance on this topic is that transplantation of patients with HCC should not occur outside of the Milan criteria. In considering transplantation, it is important for us to revisit the 4 pillars of medical ethics. First, we must ensure that there's a fair policy and system for all patients to be considered for liver transplantation. We have to ensure that a transplant is going to improve the patient's welfare. We have to make sure that the patient has the informed decision-making and the autonomy to make these decisions. And importantly, we must do no harm. We must not expose patients to unnecessary harms, and we must do our best in order to minimize the risk to these patients. Moreover, transplantation is a zero-sum game. Unfortunately, there is no overlapping benefit between transplanted and not transplanted persons. So in considering our topic, should we expand the HCC transplantation criteria? We are all for medical evolution in practice. However, in order to do so, we must make sure that we do so without compromising outcomes and also by factoring the judicious use of the limited organ supply. Unfortunately, we are not there yet. There are many different expansion criteria that have been proposed, as alluded to by our colleagues as well, but which one is the best and how do we choose which one is the best? There's many different survival variation between these different criteria, and more so, there's many new expansion criteria now that also include tumor markers, such as including AFP. So if we're going to expand our criteria, what should be included in our consideration? Is it only morphometric criteria, or should we also include these tumor markers? Going to one of the most popular studies by Duffy looking at the Milan versus UCSF and beyond UCSF, they looked at 467 patients at UCLA who fell within Milan and UCSF criteria to look at their survival estimate. Their conclusion is that patients who fell within Milan and UCSF have similar long-term outcomes. However, looking carefully at the study, we must look at the p-values on preoperative imaging, which suggests p-value of 0.06 and 0.07. When we look at the explant pathology, the p-value, it becomes even smaller at 0.05. In considering such a significant topic as transplantation, can we truly ignore such low p-values and say that it's not statistically significant, or say that it's not significant? Moreover, in the study by Duffy, they looked at the assignment of tumors to different criteria based on preoperative imaging and explant pathology. And what they found is that on explant pathology, a lot of these patients were actually reassigned from Milan criteria to UCSF and also to beyond UCSF, therefore suggesting that we cannot rely on morphometric data alone when we're deciding whether the patient should be transplanted. Moreover, looking at the table 4 in the study, when they looked at the 5-year survival rate that they said was similar, in preoperative imaging on the Milan criteria, 5-year survival is 79%, whereas at UCSF it was 64%. While not statistically significant, these are numbers that we cannot ignore. So we believe that patient, including a patient in our case, should be downstaged. In a study by Dr. Zhao, there's an increasing number of patients who are now presenting beyond Milan criteria and needing downstaging according to UNO's downstaging protocol. So what are the outcomes of these patients who are downstage? In a study by Dr. Sabri published in 2020, they looked at the odds ratio of recurrence of hepatocellular carcinoma for patients pre-TACE and also post-TACE. And what they found that patients who fell within Milan criteria after local regional therapy had a similar odds ratio as patients who fell within Milan criteria without any local regional therapy. Moreover, in another study by Ravioli in 2008, they found that the similar survival rate after 3 years between patients who were downstage and patients who met conventional criteria, essentially saying that there's long-term survival benefit in patients who are downstage is similar to patients who fell within Milan criteria. A lot of the criticism for these studies is that they were mainly single-center studies. So Dr. Mehta in 2018 published a multi-center downstaging study in which he found that the HCC recurrence in patients who were downstage was about 10.1% after a median of 19 months follow-up. He also found that after 5 years, patients who were downstage had probably survived close to 80%, which is very favorable. A multivariate analysis in this study, he found that AFP greater than 1,000 was associated with worse treatment failure, suggesting that tumor markers should be considered when we are talking about transplantation. Moreover, Dr. Mehta published a more recent paper in 2020, which compared patients who fell within Milan criteria versus patients who fell within UNOS downstaging criteria, and found that the 3-year survival probability post-transplant was similar with a p-value of 0.17. Interestingly enough, in this paper, he talked about regional differences between long wait regions, mid wait regions, and short wait regions. And what was found is that the survival probability in the long wait regions were actually associated with better survival probability with a p of 0.009, suggesting that allowing people more time to demonstrate their tumor stability and hinting at the tumor biology is important and may be associated with better survival probability. But how does this impact other patients on the waitlist if we consider transplanting these patients outside Milan within UCSF? by Dr. Perrick and published in Liver Transplantation in 2015, used a Markov model in order to measure the harm on patients on the wait list. And basically what he found is that if we transplanted a patient outside Milan with UCSF, we impose harm to other patients on the wait list within Milan, 0.4 increased risk of mortality. Patients on the wait list with a MEL greater than 30 increased about 4.2% in mortality. What he suggested is that there must be a 5-year survival threshold for which patients who would be transplanted outside Milan within UCSF must have this survival threshold in order to outweigh the harm caused to other patients. In region 5, the survival threshold is suggested to be 71%, and this is mainly influenced by the proportion of patients on the waitlist in that region with a MEL greater than 20. In the past, there has been an imbalance between patients on the waitlist with HCC and non-HCC, and what was found is that essentially patients with HCC were more likely to be transplanted. And after the 6-month waiting period, the study found that post-policy, we kind of were able to balance out waitlist mortality and dropout. But do we want to tip the scale again is a big question. Revisiting our case, we have a 57-year-old male, essentially outside Milan within UCSF, high AFP, low MEL, blood type O. Should he be transplanted now? Not yet. He would benefit from downstaging, because we want to maximize his potential benefit, whether he's receiving a deceased or living donor. His AFP is high, and we don't know his tumor stability and biology. In conclusion, we're not ready yet to expand beyond Milan criteria. We have to maximize outcomes. Downstaging is effective. We have to develop a criteria that includes tumor biology. We must make sure that we equitably allocate organs and make sure that there's not an imbalance between HCC and non-HCC candidates on the wait list. Thank you.
Okay, thank you very much for that excellent argument. We're going to go back to the Keck team to provide a 5-minute rebuttal.
Hello, all. I just wanted to say thank you for the opportunity to participate in this debate. It was very fun. And to my colleagues at Kaiser, who did a very educational and awesome presentation as well. So in regard to a few points, when we were first talking about the Milan criteria and the concern about falling outside of radiographic imaging, that's the reason why we were talking about, a more dynamic model such as the Metro ticket to really look at other things other than size and number, because there's been a number of studies that have shown that these are poor surrogates for microvascular invasion. And what has come up time and time again is the AFP is shown in Mazzaferro's Metro ticket and other studies as well. And our patient's AFP is below 400, which has been a threshold for a good surrogate marker for, no microvascular invasion. Additionally, also our patient, we have to really think about the waitlist mortality here because he's in a long waitlist region. And so when we're talking about the better outcomes that were shown in the Mehta paper for patients who had a 6-month waiting period or even longer, especially in long wait time regions, it doesn't account for the waitlist dropout. And as we cited the Kardashian paper before, there's been no survival benefit for patients who have undergone downstaging. And we would just be subjecting our patient to 6 months before he gets even listed and then even longer to get a liver. And then finally, I think, the wait times that we're seeing in our region are about 12.8 months, which is almost a year, as cited by the same paper that our colleagues at Kaiser cited. And then, I think most finally as well, if we're concerned about the utility and distribution of organs, the Markov model, which our colleagues did talk about, they cited a 72% survival rate would be acceptable and not take organs away from other patients who have HCC or who are listed for non-HCC indications, I'm sorry. And so as we showed previously, there's several studies that have been done that have shown that survival rates are higher than 72% for patients who are outside of the Milan criteria within UCSF criteria. And these are on a global scale, not just one study, but several centers across the world. And so I think that we have to give our patient a chance, and we have to consider that we are in a long wait time region. And if there's not going to be a survival benefit, we need to give this patient a liver now if there's one available. And if there's concern about distribution of organs, then we have to consider liver donor transplant as well. This is also an option. He's a well-compensated patient. He's an SVR, and we have many studies that have shown great success with living donor with less than 10% risk as well to the donor for the surgery. Thank you.
Okay, so now we're going to go back to the Kaiser group to give their rebuttal to the USC group. 5 minutes.
Thank you to the American Liver Foundation and also to USC for their great presentation. And although, we do acknowledge the points that have been made, I would like to re-examine this issue further from a public health standpoint. As we all know, there remains a scarcity of organs available for transplant. And our goal as transplant programs is to really maximize benefit for recipients. After the implementation of Milan criteria and prioritization of HCC by UNOS, we had seen significant differences in calculated MELD scores at transplants between HCC and non-HCC recipients, with HCC candidates being transplanted at much lower MELDs than non-HCC. In a retrospective study published in Gastroenterology by Berry, the MELD exception policy inadvertently led to a reduction in transplant-related survival benefit by prioritizing those with HCC. And looking back historically, over the last 5 years, we've seen UNOS react to this imbalance. And starting in 2015, they added a 6-month waiting period, which really adds to help understand a patient's tumor biology, as well as attempt to equalize the imbalance between HCC and non-HCC recipients. More recently, we've seen a pretty drastic overhaul in how exception points are being granted. And the latest reflection is when we have a patient with HCC being granted median MELD -3, with a goal of more equitable distribution of organ allocation. If we were to expand our criteria, we would thereby be increasing the HCC pool, thus exacerbating the current imbalance between HCC and non-HCC allocation. So we really do need to work towards a solution in which equitable and just allocation of organs can be achieved regardless of disease etiology. Something that the USC team had touched upon was really patient selection and additional markers. The Metro ticket was brought up. So patient selection in HCC candidates really remains of paramount importance, as this can dictate post-transplant outcomes. As my colleague Dr. Tien presented, there's a multitude of different selection criteria, and some with the addition of biomarkers that we had seen, AFP, DCP, to improve selection quality. And like we had mentioned earlier, it really remains unclear which extended criteria is best, as currently we are relying on imaging, morphometric, and biomarker data as surrogates for tumor biology, tumor aggressiveness. And as previously presented, there are significant limitations in relying on morphometric or imaging criteria alone, as evidenced in the disparities between preoperative imaging and explant pathology. And we really have to take into account these differences and in our assessment of a patient's candidacy for transplant. Expanding to UCSF, which initially started from explant pathology, which is really the gold standard. Again, going to UCSF relies only on morphometric data, and that perpetuates these limitations of imaging. For we do know, as we have increased tumor burden, we will see poor outcomes in survival and disease recurrence. So overall, we feel that HCC criteria really have not been optimized, and there remains a great need for further determination of tumor biology with the use of innovative biomarkers, as well as potential for application of things like artificial intelligence to really mitigate limitations of imaging alone. Our opponent did bring up living donor as an option as a way to bypass the waitlist and waitlist mortality. However, when we think about living donor, particularly in this case scenario, what oftentimes arises is an opportunity for expedited liver transplant, decreased time to transplant, and thus hastening of the process. In this situation, if that were to happen, we're really unable to assess this patient's tumor biology. This is the initial imaging and initial lab work. This may represent an aggressive tumor biology and ultimately lead to poor outcomes and high risk of recurrence, which would be really unfortunate in a situation of living donor, given the risks undertaken by both the donor and the recipient to undergo transplant. So we always have to keep in mind the concept of double equipoise, which is brought up with living donor transplantation, in which the recipient benefit must really outweigh and be greater than the risk to the donor. Excuse me. So for the patient presented in this case, we would say if an organ were to become available, we would not recommend proceeding directly to transplant, either via living donor or deceased donor, due to several elements of this case. One is that we do not have an understanding of his tumor biology. And in the setting of a moderately AFP, USC did quote 400, but there are other models out there that we presented where the threshold is over 100. He really may have a more aggressive disease course. So
Hi, can everyone hear me? So I just wanted to say that these are all really excellent points that you guys brought up, and our patient is certainly in a gray zone. And that's what makes him such a great debate case. We just feel strongly that we are under transplanting patients with HCC outside of the Milan criteria, and those have acceptable outcomes. And the current organ allocation system really hurts these HCC patients that would potentially have a cure with transplant. And otherwise, we're subjecting them to almost a palliative course. This patient has a chance of survival in the range of 70% at 5 years, and he has an available liver. And as Dr. Malapalli showed, these patients not only meet UCSF criteria, but numerous other transplant criteria, such as the up to 7 by Mazzaferro published in The Lancet, the Tokyo 5-5, Toronto criteria, the Metro ticket, among many others. And all of these have comparable outcomes to Milan. Sure, downstaging decreases recurrence-free survival, but there really is no survival benefit to downstaging and waiting, as evidenced by the Kardashian paper. Waiting over a year or 12.8 months per the Mehta paper in 2018, which is what our wait time is here in Region 5, is not a good option for a patient who has a liver available now. The current organ allocation system really hurts our patients, and they would die without a transplant. And right now, if I was the doctor for this patient, I have to do what's right for the patient, and I want my patient to get the best care. And for him, this would be a transplant. Thank you.
So now we'll have some final remarks by the Kaiser Group.
thank you for those points, and I definitely can understand and empathize with you, the need to serve the patient that's in front of us. However, just to close at this juncture, we feel that we're not ready to expand criteria for HCC and liver transplant on a nationwide scale. And although the studies that have been brought up suggesting comparable outcomes between Milan and UCSF, from a public health point of view, we're still struggling to balance equity between HCC and non-HCC patients. So if the HCC pool were to increase, this would swing the pendulum backwards. Once again, going against non-HCC patients who are more medically ill, as we all know. I think a big point is really patient selection. This is key in moving forward for HCC and liver transplantation. But our assessment really remains markedly limited due to reliance on data such as imaging that we know and have been shown to be imprecise. So similar to the global pandemic that we're currently facing, in which vaccines have been heralded as the holy grail, whereas in actuality, as we're seeing now, it's really the implementation of vaccination that will bring about the end of the pandemic. Ultimately, patient selection in the face of judicious and equitable organ allocation will determine the capacity of the system to expand. However, at this time, we really do lack this holy grail of HCC criteria, and thus we believe we're not yet equipped to change. Thank you.
Okay, so we want to thank these two teams. I think that was an amazing debate on a really important and issue that comes up all the time. And at all of our selection committees and our tumor boards, we often debate this this topic amongst ourselves. So I want to thank everybody. So I'm going to ask the judges to unmute themselves. And I think we'll go in backward order, alphabetical order this time. So Dr. Yang, if you have some questions for the presenters.
I mean, I really enjoyed the listening this debate. Really excellent point from both team. So I think that the both team make really legitimate point why we want to hold off transplant or proceed to transplant. I mean, I think that excellent discussion. So the question to the Kaiser team, let's say that if the MEL score is like 20, patient has some decompensation, tumor size is around like within UCSF criteria, would you advocate transplant now? Or a MEL score 25? Maybe I think that probably will be more dilemma in our practice. Question is that if the liver function is worse.
So I think at this point, you know, it's one of the principles we alluded to was in terms of justice, making sure that we still apply the same principles for all patients. You know, I understand, you know, medical practice, we have to practice on an individual basis, but, you know, when are we going to fall under this slippery slope where we're transplanting this patient and then we're just kind of further expanding our criteria for other patients? You know, I think the case is, you know, for this patient is that he has a HCC that we don't really know what his tumor biology is. We have a one-time imaging that shows that he has this HCC. You know, he would benefit more so, I still think, if he were to be downstage followed by the UNOS downstaging protocol. And a lot of the studies that we cited show that there's improved survivability benefit for these patients. So I think in this case, you know, based on what we've seen, we would still recommend that we attempt to downstage this patient if we can, in order to best benefit him and also not cause harm to other patients on the wait list.
Hey, Dr. Maelstrom, do you have any questions for the two teams?
Excellent presentation on both sides. I have a question as it pertains to supply. So there's a limited supply of organs, and in increasing the criteria or expanding the criteria for our HCC patients, is there a literature in terms of how many person years you lose for the population that would otherwise not be transplanted? And how do you reconcile those things?
Is this for the Kaiser team or the USC team, or?
I think it's a question probably for the USC team.
Sure, thank you so much. This is something Dr. Ayala and I took a look at. To be honest, I didn't find any robust data. I think the data that I found was a couple of papers whose references I can grab. The difference in transplant time depended on what criteria they were comparing. It was always Milan versus an expanded criteria, but the expanded criteria they were comparing differed. I'll have to be sure, but I think the largest window difference I saw was around the 6-month longer period. But I will back up and say, we completely agree that expanding the criteria will likely lead to a length in wait times. Then we have to step back and think, if these patients have just as good outcomes as patients that fall into MELD, like, don't they deserve to be in the wait line for transplantation?
And to add to that, I mean, this question has been asked before as we expanded the criteria to even just transplant patients with HCC. And that's where the Markov model, you know, the Vogue paper came about. And what they were showing was that, you know, that if we were transplanting with too loose of a criteria, we could have longer waiting lists, and this would create a 44% increased risk of death and a loss of 3 QALYs. But if we could keep survival rates, 5-year survival rates post-transplant at 61% or above, then we would reduce this risk, and actually we would not see this decrease in QALYs. And so the UCSF criteria and all of the other criteria that we cited have shown, a 5-year survival of over 70%. And so I think it really speaks to Rika's point that, don't these patients deserve the same treatment and the same consideration if their outcomes are just as good as someone with alcohol-associated liver disease? And as doctors, shouldn't we be giving these patients the care that they deserve and the consideration they deserve?
Okay, so Dr. Hamid, any questions?
Again, thank you both sides. You have covered a lot of our data from UCSF, which has one question. I think both sides that, we all know about the size is, we now understand that size does not matter at that much, but I wanted to get an input from both sides that with alpha fetoprotein, you did not mention if this person alpha fetoprotein, how it impact, and the new biomarker, the DCP and alpha fetoprotein L3 fraction, which are getting more into the prognostic modeling, that does it change your decision? First of all, Kaiser team, if someone has normal alpha fetoprotein with normal DCP, and same with the team from USC, if patient has elevated alpha fetoprotein, does it change your decision-making for going forward with the transplant?
I can start. So I think, that's a very good point in how looking into the future and how we're going to expand. We do know that for patients, there are select patients with HCC who do not mount an alpha fetoprotein response. So I think for us overall, and I think this is probably along the lines of what the USC team is also arguing, that patient selection or figuring out a way for optimal patient selection is key. And I think biomarkers are part of that. I don't think they are completely all of that. And that's why we take into account the change in imaging or stability in imaging, as well as even the delta or the change in the AFP has been brought up before. So I think all of those would support or add, but it would not supplant imaging or morphometric data that we have.
Okay, and then Dr. Goel, if you have a question for a particular team, either Kaiser or USC
Yeah.
team.
Thank you. Again, really good discussion and incredible review of the literature, very comprehensive on both sides. So thank you for that. A question for the Kaiser team. So when you look at this patient in front of you, some of the data that you presented refers to how downstaging could improve recurrence-free survival, not necessarily overall survival, but recurrence-free survival. Why is that important to that patient in front of you to consider?
Yeah, I think that's definitely very important because I think a lot of cases, if a patient were to have recurrence of the HCC, treating him for recurrence of the HCC becomes incredibly more difficult. And I think that's why it's very important for us to really consider and kind of, do our best in order to decrease his chances of having HCC recurrence. And I think one of the things was that in the paper by Dr. Mehta in 2020, it did kind of suggest that the UNOS downstaging, patients who fell within UNOS downstaging had similar kind of outcomes compared to patients who fell within Milan. So I do think there could be some survival benefit in these patients as well, compared to patients who just met UCSF criteria and who are not downstage. And I think one of the things is, concerning these patients, I think the survival benefit overall in patients who are outside Milan criteria within UCSF, I know that our colleagues cited most of the studies did show greater survival, greater than 70%, but even the paper by Dr. Duffy, it showed that the survival after 5 years is about 64%. So there is increased variability as well. But I think right now, we want him to have the best chances of living a long life, especially because this patient in our case was only 57 years old as well.
And then just to dovetail on what Andy was saying, we are looking at the patient in front of us, but we really can't forget about the other patients on the wait list that will die by not receiving that organ. So I think the worst nightmare for us in transplanting patients with HCC is to see early recurrence or recurrence of HCC. And that's very, very difficult because then we really haven't done anything to serve them. And not only that, we hurt the patients on the wait list who do die waiting for that organ. So there is a patient in front of us, but I think we still need to step back and think about all the other patients on the waiting list, particularly the non-HCC patients, which I think because of how UNOS initially assigned exception points and prioritization of HCC have really been left behind in this situation.
And then Dr. Mayani, if you have, oh, I'm sorry, did you have a comment?
Sorry, but I think we have to take into account that as we are moving forward and understanding HCC, we're also understanding HCC recurrence and trying to risk stratify patients who are more at risk for recurrence. And that's with the retreat score, better imaging with the multi-phase, and then also, the use of mTOR inhibitors as well, which can be anti-neoplastic. Because some of the challenges, like Dr. Tian was saying, is that putting these patients on other immunosuppressants could make the HCC even worse. And so I think that as we move forward and we get a better understanding of HCC, we're also moving forward with transplant and HCC surveillance as well. And that has to be considered. And just one site, the Duffy UCLA experience, is just one paper. So we have to look at all of the papers and all of the survival outcomes out there.
Okay, and then Dr. Bayani, any questions for either team?
I think my fellow judges have done an excellent job with the questioning, and I think the presenters have done a phenomenal job of literature review. My question is more for the transplant now argument. Really, truly, certainly there is this disconnect between recurrence-free survival and overall survival or graft survival. But I guess the question I would pose to you is, do you truly believe that there is a disconnect and that recurrence-free survival is a non-issue? Or do you think that that's a statistical or that's a statistical issue?
So that's for the USC group?
Yes, please.
I think it's something to consider, obviously, but I think, this was whether or not we should transplant him, and we're really talking about a survival benefit here, and whether or not this patient will survive. And so we're really focused on the 5-year survival rates, which are very comparable to those within Milan criteria and those that have been downstaged as well. And even the recurrence-free survival for these patients was shown with the Kardashian paper. For those who were downstaged and those who did not get downstaged were not statistically significant, the difference. And so, I think this patient, we should just move as fast as possible and try to get him a transplant, whether it be living donor or a deceased organ.
But actually, I feel like we shouldn't move too fast. And I think that's why UNO stepped in and added that 6-month rule. Just some of my thoughts, to give time to, assess the natural history, understand the tumor biology. I think the way that UNOS has been, historically changing really speaks to the way it's trying to prioritize non-HCC patients, rebalance the scales. And I honestly, I'm hesitant to move forward very quickly and not give that patient or give that tumor time to really declare itself, because if it's aggressive and he gets transplanted early, then we're looking at bad outcomes.
I think a lot of go ahead. As well that were cited that show that patients who waited the 6 months had better outcomes don't account for the patients who had, there's like an 18% dropout rate for patients here in a long waitlist period that was shown by the Mehta paper. And the Kardashian paper also, they were not able to gather data. This was, a national study, the largest to date. They were not able to account for patients who never made it to transplant. And so we're missing all of those patients who possibly could have benefited from a transplant, could have lived because they dropped out, whether it be, and this could have been a potential cure for them. And so I think we have to really think about how we could help all of our patients, not just the most optimal candidates.
So I just wanted to kind kind of do a piggyback or a follow-up question on that, which is, again, all of you guys are going to have distinguished careers, probably lead transplant centers. And at that point, you're not just looking at the patient in front of you, you are looking at the sum total of your program. And I don't mean that from an outcomes and statistics and reportable events for your program, but for the overall survival of your patients. And since each organ is going to find a home and a host, don't you want that organ and that host to have the maximal survival, which would argue for the lowest initial tumor burden and or best biology, whether you get that through incorporating tumor markers or downstaging to observe behavior and or minimizing initial tumor burden?
I completely agree. I think there is a larger questions at play, and I'm sure many of us will have to deal with it as we finish training and start our careers. I think I would just want to make a couple of points. One, there is of course a correlation, but not 100% like R=1 correlation between tumor number and tumor biology. That's the reason all these other criteria are evolving past just tumor size and number, because we want more complete proxies for how aggressive a tumor is. And then your second point about like, do we want to give livers to the people who do best? Absolutely. What we wanted to debate and what we wanted to bring to light is that the best patients are not always captured by Milan. And there are people who are just as healthy, who do just as well, if not better, that are captured in broader criteria.
So I think we're going to have to end the question and answer session because it's about 7:45. So we're going to let the judges go into their deliberation chamber and make some determinations. And we want to thank the presenters really on all four teams. I think they did an amazing job, and I'm going to send this back to Farah, and I think she's going to have some remarks.
Thank you so much. I appreciate the presentation. This is our first ever academic debate, and I really am pleased and excited about the presentations and all the hard work that has gone into your presentations. Thank you so much. And while we're waiting for the judges to make the decisions in the breakout room, let me thank Dr. Khan and Dr. Sundaram for taking this project on and guiding, helping, recruiting, and inspiring our mentors and presenters, as well as ALF staff. Thank you. We could have not done this without you. To our mentors and fellows, I know you're all very busy, and of course, we can forget that you're dealing with tremendously difficult 2020 and COVID-19. You are our heroes. Thank you for all you do, and it means a lot to us that you have taken time to participate in this event. So let's please help me give a virtual round of applause to not only the debate team, but also to our national sponsors, our gold sponsor, ASI, national bronze sponsor, CVA Specialty, and Salix Pharmaceutical, and national expo sponsors, Mallinckrodt. Thank you so much for helping us bring this information to public. And also, please don't forget that we are still working on raising funds. So when you get a chance, please go ahead and donate to us. And the donation link is on the event site as well as in your chat box. One more time, I want to remind everybody that our big event is on September 15 at 5 o'clock in the afternoon. It is called Salute to Excellence. We are honoring some of the best doctors that have been working with us. Dr. Ron Busatel from UCLA will receive American Liver Foundation's Lifetime Achievement Award. Dr. Irene Kim from Cedars-Sinai will be honored with a new award called Outstanding Women in Healthcare. Dr. Christopher Ballos from UC Davis will receive 2020 Healthcare Visionary Award for Northern California. And Dr. Edward Mena from California Liver Institute will be honored as Southern California 2020 Healthcare Visionary. There are many other honorees, as you can see on the screen, and I hope you join us in honoring these wonderful, wonderful doctors who are spending so much time, energy, and really give a lot of themselves, not only to us, but also to their patients. We have another academic event coming up, academic debate tomorrow night at Chicago, as you can see on your, Michigan, I'm sorry. As you can see on your stage. This event is also, you can join through the link and register and benefit from it. We love academic awards. I am so very happy with this one, and I'm hoping that we can do a lot more for next year. Next year, 2021, we will have many events coming out, academic debate for Northern and Southern California. We will have several of those events. The topics, the mentors, and the fellows will be chosen by the members of the Medical Advisory Council, or we call them MAC. And if the doctors that are on this event, if you are not a member of our MAC, please join us. We love to have you, and we love to have your support and also your ideas, your new ideas. Medical Advisory Council meeting, MAC's meeting, we will have altogether 8 MAC meetings between Northern California and Southern California. The purpose of these MAC meetings is that our doctors will help us understand the issues they and their patients are dealing with, and guide our activities and tell us, about the topics that we should talk about in our events and seminars that will benefit their patients. This year in 2020, we held our one liver tumor seminar in Northern California. That seminar received wonderful receptions from our physicians. We are hoping to not only do another seminar, a liver tumor seminar in Northern California, but also to bring it to Southern California and other states as well. And finally, regarding Ask the Expert webinars. Ask the Experts are local virtual seminars. During these programs, well-known liver specialists will present cases and the newest, the most updated information about various liver diseases. After each presentation, our audience will get a chance to ask questions from the doctors. This is a very popular program. I held about 6 of them this year. And I know that our patients really enjoy and benefit from having the doctors directly speak with them. So one more time, we want to show the slide with our sponsors logo, ASI, CVS Specialty, Sadex Pharmaceutical, and Mallinckrodt. We appreciate their help, and we are waiting at this point for our judges to return. Please don't forget to engage with us. We are on all social media channels, as you can see on your screen. We love to hear from you. We love to get connected with you and understand not only what you're dealing with, but also how ALF, American Liver Foundation, can help you reach out to your patients more and help them understand their diseases they're dealing with, and whatever we can do to help you. I thank you so much, all of our fellows, mentors, judges, and Dr. Khan and Dr. Sundaram for participating in this event. I am waiting to hear that when our judges are going to be coming back. I guess they're coming back right now. Dr. Sundaram, do you want to take over, please?
Thank you very much. So again, I just wanted to reiterate my gratitude to all of the teams involved in this academic debate and in this event. The event is only as good as the teams who participate, and all 4 teams did an excellent job. In my opinion, everybody was a winner, and I am happy to not be a judge because I would have had a difficult time to decide who won tonight. Okay.
Yeah. So I just want to say that, there really is no right or wrong answer for any of these things. Each group is assigned a topic, and they have to sometimes defend positions that maybe they don't initially believe in. I think it's a learning experience for everybody. And I just want to say that the mentors spent a lot of time working with the presenters. The presenters worked very hard on the presentations, and we really, really appreciate everybody's hard work. So now we're going to ask the judges to share their the criteria which they use for their decision. So I think we'll start with Dr. Bayani.
Yeah, I think we all felt very, I should just speak for myself, but we definitely thought that the presentations, both the AV as well as the data presented, were excellent. Both teams were very passionate about the use of their information and their positions. I think that both teams clearly had an excellent understanding of both positions and the angles of attack, so to speak. I think there was an excellent discussion on social justice and kind of a bigger picture on organ allocation and non-HCC disease versus HCC disease. So all around an excellent debate.
So we'll go through the criteria that we used to make our decision, I think is what we were planning to do. So the teams were given topics for their research and the position they were taking. The topics were chosen from among a long list of interesting and relevant topics, and all judges considered these elements as we evaluated the presentation. The teams were judged on their presentation skills, citation to support the case, summarize the case, and audiovisual content and style.
We also looked at the rebuttals, which were judged again on presentation skills, how effective rebutting the opposing position, and also effectively supporting their own position.
So Dr. Sundaram.
Yes, so I will ask Dr. Maelstrom when she is ready to share the winner of the first debate.
So after extensive deliberation, and even in the context of the being outnumbered as a representative from Loma Linda, we recognize the UCLA team as the winner of the first debate. And this was based on content, summation, and AV, the use of AV tools and style. So congratulations, UCLA team. Great work.
Congratulations. And I'm going to ask Dr. Yang to announce the winner of the second round and the reason behind the decision.
So yeah, it was a extremely difficult decision, as the both team really did an outstanding job of the debating actually their point. And so it was very painful for us to pick up one team over the other. The winner of this debate is the team Kaiser. The reason actually for us to decide Kaiser was that overall the discussion and was more comprehensive and addressing multiple different aspects of the organ allocations from society level as well as individual level. And also the rebuttal part was more the impressive with the Kaiser team than USC. Congratulations.
Thank you, Dr. Yang, and congratulations to the Kaiser team and to their mentor, Dr. Mittal.
Absolutely. Congratulations to the Kaiser and the UCLA teams. But thank you everybody for participating, as well as everyone who watched our debate tonight.
And we want to thank all the sponsors, the judges, the mentors, the fellows, all the academic centers. A lot of work went into this. And again, we really don't view this as having winners and losers. I think everybody's a winner because they worked very hard, and we really appreciate everybody's work. And we appreciate the American Liver Foundation for all the work that they do on behalf of patients with the liver disease.